Sir Ravi, Dr. Ravi, sir, since you are there, uh,
Yes, Dr. Das is joined. Sir is joined.
Good evening, Pratik sir.
Good evening, Pratik sir.
Good evening. Good evening. I'm just a bit late.
No problem, sir. We just now started. Allowed the audience in. I think Rajesh sir also joined. Sir, shall we start, sir? With your permission.
Yes, we can start.
Sir, we're live. We can go ahead, sir.
Dr. Pratik Das has joined. So.
Yes.
Sir, we are unable to hear you. Yes, sir.
Hello.
Yeah. Good evening, students and respected faculties. We are very happy to once again welcome you for this Regain PG program. As you must be aware, we have been constantly doing this program, and this is our edition 13 under the guidance of our course director, Dr. Pratik Das. We are very happy to welcome him once again for today's program. And I request Dr. Pratik ji to introduce the examiner as well as the examiner for the day, as well as the discussant, and accordingly take the session forward from here. Over to you, Dr. Pratik, sir.
Good evening, everybody. After a long time, actually, we have joined for this meeting because there are some irregularities. I thought that some topics have been left, so that's why you have started the program again, and will be next 3 or 4 classes. Probably we can complete the course. Today's discussion will be mainly on a case on a childhood nephrotic syndrome, and the examiner will be no other than my very good friend and brother, junior, Dr. Rajiv Sinha. He is a very renowned pediatric nephrologist in the city of practicing in the city of the Kolkata. He is a very good, excellent academic career, and he has a adequate training in abroad. Worked in the leading hospitals in UK. He has a fellowship from the Canada with vast experience in treating the patients of pediatric age group with this different kind of kidney diseases, especially the genetic diseases. He has a lot of papers in the international journal in this regard, and I am very happy to be as a part of the discussions, and we are all eager to hear from him. And so let's start our discussion.
Sir, may I start?
Yes, you can start.
Good evening, respected teachers and mentors. Today, I'm going to present a case. A 21-year married lady, Mrs. D, a resident of Belghata, Kolkata, presented in nephrology OPD on 22nd July 22 and examined by me. History given by herself and her mother, and seemed reliable. She is not known diabetic, not known hypertensive. I would like to date back my history 9 months back when she presented in our OPD with chief complaint of abrupt onset body swelling for 2 to 3 weeks and frothy urination for same duration. Following an episode of cough and cold, patient noticed abrupt onset body swelling. Swelling started in periorbital region and was prominent in the morning. And within 4 to 5 days, patient noticed swelling progressed to involve her both lower limb. Cough and cold subsided with over-the-counter medication, and swelling started after 4 to 5 days of this cough and cold. Swelling of the swelling was non-tender and was fitting in nature, and overlying skin condition was normal according to her. That was associated with further urination for same duration. However, patient did not notice any reduced discoloration of urine or any significant decrease in urine output. There was no history of any chest pain, exertional dyspnea, history suggestive of PND, no history of any urine discoloration of eye, urine, or skin anytime in her life. No history of disproportionate abdominal distension, no history of hematemesis or melena. There was no history of any systemic symptoms like skin rash, oral ulcer, joint pain, joint swelling. There is no history of any passage of gravel in urine, no history of passage of fleshy material in urine, no history of any lower urine tract symptoms like double voiding, dysuria, urgency, or hesitancy. Patient had similar episode in past multiple times, starting at age 3. This time, patient noticed at that time, patient mother noticed body swelling, which was abrupt onset, along with further urination. This was not visited by any cough or cold in the first episode. Her mother took her to a local hospital, and after initial in pediatric department, after initial evaluation, blood and urine reports, her parents were told that she was having some renal problem and leaking protein in her urine. She was initiated on oral medication, name of which her mother could remember, that was Visolon, 20 milligram per day. After initiation of medication, within 7 days, patient symptom improved with resolution of body swelling and resolution of further urination also. Patient received that medication for 2 to 3 months. Exact duration could not remember or could not produce any document. And she could remember that that drug was tapered off gradually and eventually stopped after 2 to 3 months. Patient was symptom-free for next 4 to 5 months after that, and after a course of cough and cold, patient again relapsed with further urination and body swelling within 6 months of initial episode. She was again reinitiated on the same medication and responded, so the drug was gradually tapered off. In subsequent years, patient relapsed multiple times, approximately 3 to 4 times per year, and each time treated with same medication with tapering dose, depending on patient weight. The dose was increased as he gained weight. However, patient did not have any relapse within during the tapering course of the drug or after within 1 month of stopping of drug that she could remember. Patient had multiple episodes of cough and cold and history, and most of the time resulting in relapse. Occasionally, she also had loose motion, and it resulted in relapse also. However, she did not have any history of persistent abdominal distension requiring tapping of fluid from abdomen, or any history suggestive of lower limb cellulitis. At age 9, patient noticed significant weight gain, and also patient had some difficulty in vision also. Patient had difficulty in seeing the blackboard from back bench, and it was easy for her to see the blackboard when she sit in the front bench. With this, at age 9, she had also had a relapse, and with this complaint, she visited local doctor. After initial evaluation, she was told that she was having some problem in her eye also. So this time she was initiated on a different kind of medication. This medication was given on alternate day, and with this medication, along with the previous medication with low dose, Visolon. And this medication she received for 6 months, and after 6 months, patient discontinued on her own. During this medication, patient was symptom-free, and as patient was symptom-free, she discontinued after 6 months of receiving the medication without any consultation with the pediatrician. For next 6 months, patient was asymptomatic, but next relapse happened 6 months after discontinuation at age 10 years. This time, however, she was reinitiated on oral prednisolone, which she received for 2 months but did not respond. According to her, that she received that medication meticulously, but her symptom persisted this time. So she was initiated on different kind of medication. This drug, she could remember that it was cyclosporine 50 milligram twice daily. She received for 6 months this drug, and during this therapy, patient was symptomatically improved with resolution of short urination and body swelling subsided. And during this therapy, after 6 months, patient discontinued this medication for economic reason this time. This time, patient was also advised for biopsy and some genetic testing, but patient refused that did not underwent that for economic reason. She was symptom-free until age 17. This time, she visited local doctor and was until age 17. Then again, she noticed mild form of fraud urination and body swelling. But this time, her symptom did not affect her day-to-day activity. So she did not ask for any specialist help. She visited local doctor and was advised some oral medication. Following this medication intake, she used to pass profuse amount of urine, and her body swelling subsided for a few days, but fraud urination persisted. She self-medicated on this medication off and on as her body swelling reappeared, but did not consulted any specialist help. 9 months back, that is until age 20 years, she had a relapse. This time her symptom was severe and resulting in admission in nephrology ward in NRS Medical College. This time after evaluation, she was told to undergo some procedure by lying supine, and some needle was inserted on the left side of her back. After initial evaluation, patient was told that she was losing protein, and exact amount she could remember that 4 grams per day. And however, her serum creatine was normal, but exact value she could not remember. After therapy, she was after this procedure, she was initiated on medication tacrolimus, initially 1.5 milligram twice daily, and after 1 month, this medication dose was increased to 2 milligram BD. With this therapy, her symptoms resolved within 2 months, 1.5 months of the therapy. There was no history of any hearing difficulty. There was no history of any Ayurvedic medication or alternate medication. Birth and developmental history. She is a child of non-consanguineous marriage, normal vaginal delivery, birth weight. Her mother could remember that she was 2.8 kg around. One other sibling, she had an elder sister. She is normal. According to her mother, she achieved developmental milestone as per her peer. However, in peripubertal period, she did not gain height as her sister gained height. Her scholastic activity was normal, but as she was frequently ill in her childhood, so she was admitted in class 1 when she was 7 years old. But she dropped out of school when she was at class 9 due to her some family issue and economic problem. Immunization history, fully immunized up to age 3 years. Thereafter, she did not receive any immunization. However, she could not produce any documentation. Menstrual history, menarche achieved at 11 years, cycle regular, 28 to 30 days cycle. Bleeding persisted for 3 to 5 days, and amount was normal. Family history, elder sister, one elder sister, normal. No family history of similar illness or any kidney disorder in the family. No history of any hearing loss or vision difficulty in any of her siblings or cousins. So, socioeconomic history, beautician by occupation, lived in a pakka house with access to sanitary latrine and clean drinking water. Sir, may I go to the examination? On examination, patient is alert, conscious, cooperative, higher function normal, oriented, time, place, and person. Build height is 4 feet, weight is 40 kg, BMI is 26.9 kg per meter square. Anemia, cyanosis, clubbing, jaundice, edema is absent at present. And neck veins not engorged, neck glands not palpable. Skin, generalized skin conditions, stria over abdomen. And onycholysis on right hand, index finger and middle finger. BP in right upper limb in sitting posture after 5 minutes of rest is 120 to 80, and left upper limb is 118/78 millimeter mercury. No postural drop. Pulse is 86 per minute, regular, no special character, no radioradial, radiofemoral delay, arterial wall non-palpable, all peripheral pulse are palpable equally. Respiratory rate 18 per minute, thoracoabdominal. Systemic examination. Genitourinary per abdomen, inspection, no scar, flanks are full, stria, multiple pink stria and on the flank, umbilicus central inverted. On palpation, no organomegaly, no tenderness on superficial or deep palpation. Percussion, fluid seal and shifting dullness absent. Cardiovascular, precordium normal, apex beat at 5th intercostal space, 1 inch medial to mid-clavicular line. No parasternal heave, S1, S2 audible, no adventitious sound. CNS, higher function, cranial nerves, motor sensory and cerebellar function normal. Bladder valve control normal. Respiration, upper respiratory tract within normal repeat. No tenderness over, no sinus tenderness over any sinuses. Nasal septum is not deviated. No discharging sinus or polyp is visible. Trachea central, lower respiratory tract, bilateral vesicular breath sound, no adventitious sound, no pleural effusion. Eye examination, bilateral immature cataract, fundoscopy, retina could not be visualized due to hazy media. Hearing, auditory system, Renal's air conduction is greater than bone conduction and Weber's not lateralized. Urine dipstick, protein is nil at present, urine RBC is nil. So may I summarize the patient?
Yes. Nice history and the clinical examination. What you can do is that you can summarize the case first and then tell us what is your differential diagnosis or provisional diagnosis.
Summary: 21-year lady, child of non-consanguineous marriage without any comorbidity. A follow-up case of nephrotic syndrome, age of onset being 3 years. Initially steroid responsive, behaved like frequently relapsing nephrotic syndrome. Due to steroid toxicity, received a steroid-sparing agent levamisole, probably levamisole, for 6 months at age 9. Secondary steroid resistance documented at age 10 and treated with cyclosporine for 6 months inadequately. Presented now with fresh relapse at 20 years. Underwent renal biopsy, now in remission with tacrolimus 4 mg per day with steroid toxicity as short stature, weight gain, overweight, bilateral immature cataract.
And at around 10 years, when the child became a secondary SRNS, then did she respond to the CNI?
Yes, sir. Patient responded with CNI. Patient was symptom-free for 6 months during the therapy and another 6 months during the therapy.
Was there any documented response? Like, do they do a dipstick at home?
Yes, sir. Patient used to do dipstick, and according to her, patient was symptom-free around 1 month of therapy.
After CNI?
After cyclosporine, 50 mg BD.
And since then is having recurrent relapses. And what is important to know is, like, to understand is that in this period when they were giving steroid, was the urine becoming negative or trace for continuously 3 days?
Yes, sir. She used to do dipstick at her home, uh, as told by pediatrician. And when her dipstick become negative consecutive for 3 days as test on negative, she was advised to visit the pediatric OPD when she was in one steroid, and dose was reduced according to her.
And even now she is steroid sensitive.
No, sir. Steroids patient. Actually, there was cataract, so we did not try this time steroid. And patient had a documented received 2 months of steroid prior to cyclosporine at 10 years.
No, but I'm asking that after cyclosporine also she was having recurrent relapses. No, once she stopped the cyclosporine. So during this period, do we have any documentation whether she is still steroid sensitive or not?
There is, sir, patient received cyclosporine. Following that, patient during her peripubertal period, patient did not visit any doctor, but as patient was symptom free. She again reappeared. She noticed pedal swelling and fluctuation again when she was 17 years old. But at that time, her symptom was not bothering her, and due to economic reason, she did not visit any specialist. She visited local doctor, and probably she was advised some diuretic. She off and on she was on diuretic as her symptom was mild pedal swelling, so she could go on with her daily activities. But her actual symptom reappears when she was 20 years of age. According to her, this time her body swelling was very severe and fluctuation was very severe. So she got admitted in nephrology prior to her marriage.
So currently she is not doing a dipstick at home.
Currently, sir, patient in remission. Patient is 21 years.
She is not doing dipstick at home.
No, sir. We are monthly checking her urine REM and 24-hour urine. By that, we documented remission when after 2 months of tacrolimus. Initially, she was 1.5 milligram tacrolimus BD, and after 1 month therapy, her TAC level was low, so we increased it to 4 milligram per day, 2 milligram BD.
And anthropometry wise, what is happening?
Sir, her height is 4 feet, but I did not measure the arm span and upper segment, lower segment.
Yeah, 4 feet, I don't understand. So, is she short?
Short. According her mid-pan, she is shorter than her mother. Her father, her family member, his tallest is her father, and next come her sister, then come her mother, and then she is the brunt of the family.
Did you put any centile? She's 21 years, so you can plot till 18 years at least. So did you put her on any centile, both centile?
No, sir. I did not measure that.
Okay. And weight-wise?
Weight-wise, her weight is 40 kg, and BMI comes 26.9 kg per meter square.
Which is
overweight. Sir.
And being a pediatric nephrologist, we are very focused on growth. No? So that's something we'd like to know, that what centile is she? But from what you have said, I understand that she is short and fat.
Yes.
So why do you think she's short and fat?
She had a chronic history of renal disorder that might hamper her growth. Again, she has received a prolonged period of oral steroid that also stunted her growth, resulting in growth failure, linear growth failure.
What is the creatinine at the moment?
At present, patient creatinine is 0.9, sir.
And the EGFR comes to?
EGFR is
which formula are you using?
CKD BMD, sir. CKD EPI.
EPA, yeah.
She's 21 years and creatinine is 0.9. 91.47.
So is she CKD?
Any history of more than 3 months of chronic proteinuria is also CKD.
But have we documented that she has had 3 months of continuous chronic proteinuria?
Continuous proteinuria in between she had received remission.
Yeah.
That is
So
documented, but we can.
Is she CKD?
I will not stamp her as a CKD.
So her growth problem is most probably not because of CKD, right?
Yes.
Not because of the kidney. The growth problem is most probably because of the chronic steroid. But then after 13-14 years, she has not been taking any steroid, that much of steroid, no? You said?
Yes, sir.
Then why is the growth still a problem? Because after 13-14 years, the steroid was stopped.
I don't know, sir. Why the growth problem? Steroid inhibits the cartilage growth, metaphyseal growth, so linear growth is hampered.
Yeah,
and
but then
suppress.
for the last like after 13-14 years, she's not taking steroid. So most probably whatever has happened before, no? And
Yes.
and usually you don't grow after 13-14 years, do you? Usually you reach your maximum growth around 14-15 puberty. So most probably she was steroid must have been given in a large amount before that, and even after stopping steroid, she could not achieve the catch-up growth.
Yes.
The other thing is like initially, any idea whether initially she was steroid sensitive, right?
Yes, sir.
And then she became steroid resistant. She had some CNI, but and then what happened, we don't really know that well. And now she is in remission courtesy to CNI. Now, if this child goes into renal failure, what are the post-transplantation? What are the chances of recurrence?
If MKD is not known, most common this patient probably the nature of the disease that patient is steroid did not responded to steroids. So this might be a FSGS, and biopsy also shows that FSGS. So in FSGS after post transplant recurrence is around 30%.
So
in graph,
FSGS can be initially steroid sensitive or can be steroid resistant right from day one, right?
Yes, sir.
So in this particular child who was initially steroid sensitive, is that a good prognosis or bad prognosis for post-transplant recurrence?
If the patient is steroid responsive, it is always good.
I'm again repeating my question, and it is a hypothetical question. But suppose this child goes into ESRD, end-stage renal failure, then is it better to be a primary steroid sensitive or secondary? Sorry, is it better to be primary steroid resistant or secondary steroid resistant for recurrence? The difference between primary and secondary steroid resistant is like whether initially the child was steroid sensitive or not. Yes. So again, pinpointing, if you are steroid sensitive and you become end-stage renal failure, then post-transplant recurrence is higher, or if you are steroid resistant right from the day one, then the post-transplant recurrence is higher. Am I clear with my question?
Yes, sir. Yes, sir. I don't know, sir. I didn't.
So, steroid sensitive, if you are steroid sensitive, then you are less likely to go into end-stage renal failure, right?
Yes, sir.
That we know very
That
well.
means.
But if you go to end-stage renal failure, like if the child now becomes secondary resistant and refractory to CNI, then the chances of recurrence is much higher. Okay. So now what is your plan for this child?
At this
You
patient,
have done a biopsy.
yes,
So and the biopsy was FSGS.
FSGS NOS.
Yeah. Any other information that you'd like to share on the biopsy, or which I'd like to hear?
Yes, sir. I will see for any IFTA chronicity.
So
IFTA
was
is
there any
high, then
chronicity?
it was 5 to 10%.
Is that significant?
No, sir.
Not that.
It's low.
So then how will you manage this child, this girl?
At this patient responded with CNI, so I will continue CNI tacrolimus. Target tacrolimus in adult patient is tout level, keeping that 5 to 10 and within that range, as low patient maintaining remission with lowest possible dose of tacrolimus. And if patient is receiving tacrolimus for more than at least for 1 year, I will give it for at least minimum for 1 year. If the patient is requiring tacrolimus for more than 2 to 3 years, repeat biopsy in background of renal function to exclude TAC toxicity, we can go for that. If
And,
at this time patient,
and if there is no deranged toxicity, then would you go for a biopsy?
No, sir. I will try to taper off. I will try to stop the tacrolimus for after 2 to 3 years. If patient is maintaining remission or not, I will go for that.
And if you have to continue on tacrolimus, then you'll go for a biopsy after 2 to 3 years.
Yes, yes.
So what are the incidents of CNA toxicity on renal biopsy at 2 to 3 years?
Exact data I do not know, sir.
What are the features of CNA toxicity on renal biopsy?
Chronic CNI toxicity results in striated cortical atrophy, fibrosis, striate cortical fibrosis, and arterial hyalinosis.
And
in acute toxicity, proximal tubular isometric vacuolation also there.
So suppose this child has responded to CNI. I will go on telling child because that's what comes to my mouth. So she has responded to CNI. You are maintaining a TAC around say 7, and then the child relapses. Then what do you do?
I will first check for compliance. If compliance is good, then possibility of other factor of proteinuria to be excluded, like UTI and other factors.
UTI, there is no UTI, and you looked at the TAC level also. It was about 6.5. But she has relapsed.
I can try a higher dose of tacrolimus with keeping the target range. If in spite of that, the patient did not respond in this time, I will stamp her as a CNI failure.
Okay. So what is the incidence, or what is the chance of the child becoming a steroid sensitive?
After steroid resistance.
After steroid resistant, and after giving and becoming CNI responsive, what are the chance of the child of that becoming steroid sensitive?
Yes, I don't know.
Is it possible? So studies have shown that these children, those who become CNI responsive, can become steroid responsive. And we all know the best medication for inducing remission is what? Steroid.
Sure.
We have to come down quickly, but the base medication is steroid. So I would personally, I don't know what adults do, but at least till 18 years, like the age range where I am legally supposed to see, I would definitely try steroid and see whether the child is still steroid responsive or not. Next question comes. So suppose this particular lady, you are trying steroid like this, response to CNI and then relapses, you try steroid and the child again responds to the steroid also. So has now become steroid sensitive. As I said that many a time it can happen. Many a time secondary steroid resistant nephrotic syndrome can become steroid sensitive nephrotic syndrome after responding to CNI. But now we are saying that as soon as we are tapering down the steroid, then the child is again relapsing. So what we are having now is a child who is steroid dependent, CNI dependent. Okay. Now what will we do? And we have checked the CNI level. It is around 7, 8. It is maintaining a good level.
MMF might be tried.
So will you stop CNI and then switch to MMF or what? Or you will add on MMF?
I will add on MMF.
There has been a randomized control trial which has shown that MMF is inferior to CNI in maintaining remission in this CNI dependent SRLS.
Yes.
And add-on MMF is we have done very rarely. We have done that, but then that has the chances of high infection, no? Because then the child is on steroid, CNI, and MMF. Any other option?
Rituximab might be tried.
Very good. So, what is the evidence for that? So, we have a strong evidence coming up showing that rituximab can work very well in FSGS, right?
Yes.
And in this sort of cases, we will first try rituximab. So, how many doses of rituximab would you give?
1 to 4 dose, 375 milligram per meter square body surface area in each dose. And targeted therapy should be CD19 count should be less than 5 microgram per 5 cell per microliter.
So whether you will give 1, 2, 3, 4.
First 2 dose I will give. First 2 dose, 15 days we have 2 dose, 375 milligram per meter square per dose. After that, I will check for CD19 count, CD19 positive B cell count. If the target dose is achieved, I will repeat that count after 6 months. If that it is inadequate, I will repeat another 2 days.
They had already achieved a CD19 of less than 5. So if there is a relapse, like if the CD19 comes up again, then you repeat another 2 doses.
Yes,
that's what you were saying, no? Yes. So suppose if I check after first dose and the CD19 is less than 1%, then what will happen? Then would you give the second dose? Okay, tell me, how does rituximab works in nephrotic syndrome?
in nephrotic syndrome, usually rituximab is a CD20 targeted marker. It acts on B cell, but it also binds off target. Off-target podocyte cytoskeleton stabilization by sphingomyelin dephosphorylate surface protein.
SMPLD3. Yeah,
SFPLD3B. It binds with that, and it it stabilizes the actin cytoskeleton, resulting in stoppage of podocyte effacement.
That is the direct action. But it was first shown by someone called Mundell et al. But then this has not been replicated in other studies. What are the other way in which it works? Because we all know that nephrotic syndrome is a B cell, is a T cell. No.
T cell.
Then how does depleting B cell work?
B cell might act as an antigen presenting cell also.
How? Okay, let's go back to the start. So this child was a steroid sensitive nephrotic syndrome who went on to having either a frequently relapsing or a steroid dependent nephrotic syndrome, right?
Yes.
And was given levamisole.
Yes.
So was the choice of levamisole right or wrong? Any guideline which says like when you should be choosing levamisole?
In frequently relapsing nephrotic syndrome without any sign of steroid toxicity, we can give levamisole. But if there is a severe steroid toxicity or life-threatening relapse, we can go for higher dose of MMF or cyclophosphamide.
So in this particular child, maybe the choice of levamisole was not correct at that time, because child already had a steroid toxicity and was having high threshold. So the recent guideline says that if your child is relapsing on a high threshold, say 1 milligram per kg alternate day, then better not to use levamisole. Then what will you use? Cyclophosphamide or MMF? Suppose money is not a factor, and nowadays even in medical colleges, I have heard that you get MMF free of cost, right? So what would you use, MMF or cyclophosphamide, and why?
If steroid dependent, then I will consider MMF first, because in steroid dependent, cyclophosphamide does not perform well.
So is there any evidence, is there any trial which has a head-to-head compared MMF with cyclophosphamide? Because you just said that in steroid dependent MMF works better than cyclophosphamide. Is there any head-to-head trial?
Yes, and there was in KDIGO it was mentioned that multiple trials, but sample size was very small.
Up till now there is no head-to-head trial which has compared. As far as I know, there are no head-to-head trial which has compared MMF with cyclophosphamide. But retrospective analysis have shown that that MMF works better in younger age group. But that is also taken with some pinch of salt. So what is the advantage of cyclophosphamide and its disadvantage?
Cyclophosphamide therapy is short. It's 12 weeks therapy first. If the disadvantage is gonadal toxicity and other, it's a higher form of immunosuppression. Cumulative dose crosses 168 milligram per kg. Then there is gonadal toxicity and bone marrow suppression.
Very good. So like whenever we prescribe, we make sure that we are not exceeding that 167 milligram per kg, 168. And the other very important plus point of cyclophosphamide is that it is among, if you think it deeply, it is among the only drug where if it works, you can be off medications, off all medications for maybe few months or even a year and more. Because even when you are using MMF, you are continuing to use MMF. Whereas when you use cyclophosphamide, 2 to 3 months, and then you stop cyclophosphamide, win off steroid, and you can be off all medication. That is a a big advantage of cyclophosphamide. We are using cyclophosphamide quite frequently. And gonadal toxicity, we just try to explain to the family that with 167 milligram per kg, the chances are minimal, particularly in the younger, like when your puberty has not developed that much. So, and if the MMF and cyclophosphamide fails, then what will you do? So we are now discussing primarily steroid dependent and frequently relapsing.
Then we can go for CNI.
Which one would you choose, tacrolimus or cyclosporine?
For cyclosporine has cosmetic problems. So if a female child peripubertal time, so I will go for TAC, gum hypertrophy. If there is a metabolic problem is more, diabetes, obesity, so then I will consider cyclosporine.
And efficacy wise, any difference? No, they are almost the same. But so in a steroid resistant nephrotic syndrome, which drug would you use? CNI, cyclophosphamide, MMF as a first line drug.
In steroid resistant, there is no role of cyclophosphamide. I will go for CNI. MMF might be considered if creatinine is raised.
Very good. That is a very important take-home message that cyclophosphamide, there has been number of randomized control trial, I believe 2 to 3, including one big trial from AIMS, saying that CNI is far superior to cyclophosphamide. So for the SRNS, we should go for CNI. Before you give CNI, will you do anything for SRNS? You will do the biopsy.
Biopsy.
But anything else?
Any kind of resistant, I will go for biopsy. It might be primary resistant or secondary resistant, age of onset more than 12 years, I will consider biopsy.
Although the pediatric guideline, be it the Indian or the international, says that even now, if you are starting CNI, you should go for a biopsy, even for SDNS. So that's something the adult world doesn't do. But the pediatric guideline says that if you're starting CNI, you go for a biopsy. But my question was that in a steroid resistant nephrotic syndrome, while you are starting CNI, would you, and you have done the biopsy, would you go for any other test?
Genetic testing, primary resistant, genetic testing I will consider. Because in monogenic mutation, we do not continue CNI.
And for secondary resistant, you would not go for a genetic testing.
That is not, I have not read in that time.
No, you're right. So if resource is a constraint, and if you're very sure that the child is secondary resistant, then there is no role for genetic testing. So what is the common variant that you might be finding
in biopsy or
in genetic testing?
NPH2, NPHS2, podocin mutation, followed by WT1 also is there. And
problem is that we read a lot of the Western literature, but Western literature shows podocin is the commonest. But if you read the Asian literature, including Indian, podocin is not the commonest. And what about nephrin mutation? When are you likely to find it?
Nephrin is there also. NPH.
At which age group you are likely to find it? In the younger, like a congenital nephrotic syndrome, that like within 3 months or within 1 year, nephrin is more common. After that, they are less common. And lastly, in this particular So going back to this particular case, what we discussed is that we would continue on the CNI maybe for 1 to 2 years. I would go for at least 2 years. Because if she has responded, I don't want to rock the boat. Go for 2 years with regular monitoring of the renal parameters and the CNI level. And if if there is a relapse, then I would definitely try a steroid. If the child is steroid sensitive, well and good. If the child becomes steroid dependent, then I would personally go for rituximab and continue on the CNI and see whether rituximab can maintain the remission for a longer time. What about future? So childhood nephrotic syndrome, what percentage of them go on relapsing even after puberty?
In around 80 to 90% relapse, even after fast response, 80
No.
to 90%.
No. My question is childhood nephrotic syndrome after puberty. Like usually we are told that childhood nephrotic syndrome is a benign disorder, and around puberty everything will get better. That is what they are told. So what percentage of children of childhood nephrotic syndrome, steroid sensitive nephrotic syndrome, go on relapsing even after puberty?
30%, I would say. 30%.
So quite a high percentage. That's something that we usually don't tell the parents. And the studies have shown that their long-term outcome can be quite difficult. Like studies even from the Western world, they have shown that like they have got lower education, their working problems, all those things are quite significant. And particularly, for example, in your girl, because she has become short, she will definitely be like depressed, and like psychological problems will be quite high. Okay, Pratik da, বোধহয় হয়ে গেছে, আর তো কিছু বলার নেই আমার। You have any questions you can ask?
No, just I am just listening. This is like a good teacher you have taken is every practical problem. We actually don't deal in that detail, and so this is Muhaiminul also learned from these that how to take a history. I just one comment to him that basically during taking a history you should highlight your points. This is not just going on report just like a newspaper reporting. The history should be slightly precise and highlighting the important issues and identifying the problems in that particular patient. And probably you have learned that how these experts they are practicing with such kind of patients. I think Dr. Ravi Ranjan is there and he will summarize what has been discussed in today's class basically. Ravi.
Thank you, sir. Thank you, sir. It was pleasant to hear all those questions. I have been listening to you for last 4 or 5 years since we were students. So every time I listen to you, we understand nephrotic syndrome in different perspectives. So there are so many questions to be asked, and we never know all those answers. So today's discussion was based on a nephrotic syndrome, childhood or pediatric onset. Initially had frequent relapse, later on became steroid resistant and treated with multiple therapies other than steroid like levamisole, cyclosporine and tacrolimus, and presented presently with anasarca and kidney biopsy showed FSGS. And sir has emphasized precisely on the dipstick home monitoring. That is a very important issue to know whether the patient actually is in remission or not, which we often miss in our day-to-day practice. Sir also told us the importance of anthropometric measurements, specifically if the child is short, and the importance of growth chart and the centile-wise how in which centile the child is in. And the common causes of short stature in nephrotic syndrome, whether this is because of the chronic kidney disease or because of the drugs, those are being used, specifically the steroid. And most of the growth, linear growth, occurs till puberty. Sir has told us about the renal function measurement, specifically eGFR calculation by CKD EPI, and the definition of CKD. This is only not only the GFR, but also the presence of proteinuria, and if they persist for more than 3 months, and that also be included in the definition of CKD. The chances of recurrence of post-transplant nephrotic syndrome cases, if the patient is steroid sensitive vis-a-vis steroid resistant, and also if the patient is primary steroid resistant vis-a-vis secondary steroid resistant. So usually the secondary steroid resistance patients have less chance of ESRD. If they are steroid sensitive, they have less chance to go to ESRD. The importance of kidney biopsy, the role of chronicity or IFTA that decides whether which mode of therapy or treatment we have to choose. The importance of repeated kidney biopsy in nephrotic syndrome patients. The features of CNI toxicity, specifically in biopsy. What should be done if a patient becomes CNI resistant? Can a patient become steroid sensitive even after treating with CNIs? We learned about what should be done in patients with steroid dependent and CNI dependent nephrotic syndrome. What are the possible options? And probably rituximab is the best one. And the dose schedule, the mechanism of actions, the evidence of levamisole in nephrotic syndrome, the steroid dependent nephrotic syndrome, and the choice of drugs, like whether to use cyclophosphamide versus MMF, the advantages and disadvantages of each drug, specifically the gonadal toxicity and bone marrow suppressions, and the difference of using the tacrolimus versus cyclosporine. They are efficacy wise, they are equal, similar, but they have different side effect profile. Sir has also told us about in steroid resistant nephrotic syndrome, the main drug which should be used is CNI, which is preferred than MMF, and very less evidence for the cyclophosphamide. And the common genetic mutations internationally and in Indian populations, and the chances of relapse of nephrotic syndrome even after puberty, which is actually very high. So there were a plethora of questions Sir has asked you, and probably most of the questions have been dealt with by the student. So this was quite a good interactive sessions, and I congratulate you that you have done well. Pratik sir and sir will give you final comments about your performance today.
Thank you, sir.
And the history was quite good, and like right from day one, whenever we are taking history, but this is like, it is always easy to comment when you are on the opposite side of the table. But whenever we are taking history, we should be, and that's what the examiner also wants to hear, is that whether you are having a constructive thought process. So when Pratikda said that your history should be concise, but he meant primarily was that when the examiner is listening to you, he is understanding that how you are progressing. Like I try to look at the history as a sort of a detective work. No, you are doing the detective work so that at the end of it, you can come up with 2 or 3 differential diagnoses. So your history should be highlighting those points, which will be helping you to come up with the differential diagnosis. And if that stucks with the examiner, then you are pass. So I think overall it was quite good. Your knowledge was quite good. And yeah, I mean, we need to obviously go through the KDIGO guidelines, including the pediatric, because most of the thing that we discuss are in the KDIGO guideline also for the pediatric part.
Thank you.
Pratik,
Yes, basically, exactly what I was thinking, Rajiv has told you. So this is basically in the examination-oriented classes mostly. It's a learning also, but at the same time, how to go about time is important, and the history is very important. So thank you, Rajiv, for coming.
thank you very much. Thank you very much.
The next few classes also we may ask you, and then maybe not in this session, next session. And
so there is a question in the chat box about how does rituximab target T cell. So that's something that can be read up, and that is a common question that comes in the Viva, etc. So like how does rituximab help in nephrotic syndrome, which is primarily a T cell? So ওটা আমি answer বলবো না, you can read up in the, it is available everywhere. Okay. Thank
okay.
you.
Thank you.
Thank you very much. Bye. Thank you.
Okay.
Thank you, Ruby. Bye.
Thank you, sir. Thank you. So let us end the session. Over to you, NK Raja, Mr. NK Raja. He is there or not? Probably he's left.
Rajesh sir is not there. You can end.
Okay. Then you can end the session.
Thank you very much, all the audience. During this Saturday night also, more than 60 doctors have been joined and shown the interest for seeing this case presentation. And we are thanks for Dr. Rajiv Sinha sir for accepting as an examiner and guiding us by Dr. Pratik sir and Dr. Rabi sir as a moderator also. We thank all of our audience and our faculty members for helping us. We'll next program will announce soon. Good night. Thank you, sir.